everyone. Well, welcome to this week's acid base conference. I'm going to continue from the previous talks for those that have attended, but I'll review a few of the salient points. So, and I'd like to maybe have the fellows interact a little more with this one. So on this slide, again, the top line shows the carbonated species that are in blood. Does anyone want to review that equilibrium for me? Does anyone feel comfortable naming the four of them? No? Okay. So what it says is, again, that carbon dioxide with water forms carbonic acid, the H2CO3, which can break up into a proton and bicarbonate, which can further break up into a proton and carbonate. So when we measure the total CO2 in the blood chemistries that comes along with the BUN and creatinine and electrolytes, you're measuring the sum of all of these, but only two of them are in the millimolar range. The bicarbonate is around 24 millimolar, and the carbon dioxide is around 1.2 millimolar. You calculate that by multiplying 0.03 times the PCO2. Remember, when you have a gas in air above water, some of that gas is going to dissolve, and that's what happens with carbon dioxide. So when we talk about the partial pressure of carbon dioxide being 40 millimeters of mercury, that's the volatile part, that's the air, but in the blood itself is 1.2 millimoles per liter of carbon dioxide with that pressure of 40 millimeters of mercury, and you convert one to the other by multiplying by a constant called the solubility coefficient, which is 0.03. So at a PCO2 of 40, you calculate that there's roughly 1.2 millimolar dissolved carbon dioxide. So if you add this to the bicarbonate, you get 25. The reason we don't worry about the carbonate and the carbonic acid is they're just very, very low in normal blood. They're in the micromolar range. So again, we call it the total CO2. Do not call it CO2 and do not call it bicarbonate. The only way we get a bicarbonate concentration is by calculating it from the blood gases. There's no measurement of bicarbonate clinically. It's always calculated. Whereas this is measured. The total CO2 is measured. Again, when you're confronting a patient and you want to assess whether there's an acid-base disturbance, you make your mind zero in on the total CO2 or the bicarbonate, and you answer the question, is the bicarbonate decreased, normal, or increased? If it's decreased, it's either a metabolic acidosis or an acute respiratory alkalosis or a chronic respiratory alkalosis. The distinction between these depends on how much the PCO2 changed compared to how much the bicarbonate changed. It is not based on how much the bicarbonate changed. So don't say that the bicarbonate fell by this, therefore it must be a metabolic acidosis. That's not true. They can all three have the same lower bicarbonate concentration, and you can't distinguish them from the bicarbonate per se. You have to look at the change in the PCO2, which is the telltale point. That tells you the distinction between the three of them, because they have a different proportionality, which you have to memorize. We've gone over this a few times. It's empirical. You can't figure this out from first principles. It's just the way humans respond in these three different acid-base disorders. So you memorize them and then see whether your patient fits into one of the three. If the bicarbonate or total CO2 is elevated, then it's one of these three. So it's always one of three things. And if it's normal, remember that you can also have an acid-base disorder like we talked about last week. You could have a metabolic acidosis and alkalosis that are equal in magnitude, but they change the bicarbonate in opposite directions. But if they quantitatively affect the bicarbonate the same way, you'll end up with a bicarbonate of 24, 25. And then, of course, you don't need a compensation, so your PCO2 is not going to be any different. You'll have a PCO2 that's normal, a bicarbonate that's normal, and a pH that's normal. And the only clue you might have is that either you have hypokalemia or dysnatremia, or you have a change in the anion gap. If you have none of those things, then you have to go by the clinical situation or possibly other clues in the urine. It gets harder and harder. But typically on an exam, they'll give you a patient with an anion gap type metabolic acidosis, who also has a metabolic alkalosis of equal magnitude. So all the acid-base numbers are normal, and the only clue is they have an elevated anion gap. But as I said last week, if you have someone with diarrhea or a non-gap acidosis who has a metabolic alkalosis and they're equal in magnitude, then you won't have a change in the anion gap, and you might miss the fact that there's actually two acid-base disorders going on. So I didn't mention this before, but that's why we distinguish the word osis from emia. Osis, we say metabolic acidosis, and when we say that, we're saying there's a process involved that could potentially create acidic blood, or what you should say is acidemic blood. The blood's acidemic. But just because you have a metabolic acidosis doesn't mean that the blood's going to be acidic, because you could have a metabolic alkalosis of equal magnitude. So osis is a process that would tend to change the blood by a certain way, but it doesn't mean that the blood has changed. Simply because if you have more than one acid-base disorder, they may all be summing up. You could have 3 or 4 different acid-base processes going on, but the sum quantitatively of all of them is normal numbers. So you always have to remember that clinically, that the lack of change in these numbers does not at all tell you whether there's a bunch of processes going on that could be changing the numbers. And conversely, if you have one of these disorders, it doesn't mean that the blood pH or numbers are going to change, because you could have a complex set of things going on in more than one disorder. And you could have two, you have at least 2 things going on, but you could have 3, 4, or 5 acid-base disorders, all summing up on the alkalotic and acidotic side to end up being, well, there's nothing changing, because they're equal in magnitude when you sum up their quantitative significance. So you always have to keep that in mind. So again, each of these things we divide up 2 ways. Metabolic acidosis, we divide up by whether the anion gap's elevated. Metabolic alkalosis, we divide up whether it'll respond to chloride or not by looking at the urine chloride as a predictive measurement. If the chloride is very low, it suggests that if you give chloride containing salts, the bicarbonate will decrease to normal. Whereas if the chloride is normal, remember, not elevated, but just normal. In other words, the chloride is what yours would be on the same diet of chloride and the same water intake. That will not respond to giving chloride, such as someone with Barter's or Gilman syndrome, that kind of thing. They just excrete their dietary chloride like you do in the same volume of urine, and you can give them as much chloride as you want. The bicarbonate's not going to budge. They're just going to dump the chloride. Respiratory acidosis, we don't divide by compensation. We don't divide by anion gap. We don't divide by urine chloride. We divide by a temporal subdivision that we call acute or chronic. And the same with respiratory alkalosis. We never use the word primary or secondary, so rid that from your vocabulary. We don't use the word superimposed when we talk about acid-base diagnoses. If there's more than one, we just say there's a respiratory alkalosis present, there's a metabolic alkalosis present. We don't say the patient had a metabolic alkalosis with a superimposed respiratory acidosis. That sort of has other implications that you don't want to necessarily convey, nor do you necessarily know about. So we just say these are the diagnoses that are present with this snapshot at this point in time. Okay, so does anybody want to tackle this patient? Why don't one of you go through the thinking? Don't be shy. Best way to learn is to do it yourself. So anyone want to go through the numbers again? You zero in on the bicarbonate or the total CO2. Anyone? Okay. Well, again, you ask yourself, what is the bicarbonate or the total CO2? And it's down. So does anyone want to tell me what the 3 possible acid? It's always one of 3, or 3 globally, 3 potential that you have to then distinguish from. So what are the 3 acid-base disorders that lower your bicarbonate?
A metabolic acidosis or a chronic respiratory alkalosis or an acute respiratory
Yeah, very good.
alkalosis?
Very good. So it's either metabolic acidosis or acute or chronic respiratory alkalosis, and we look at the PCO2 to distinguish. And we see here that the PCO2, we don't know what the original numbers are. That's always the problem when we're analyzing acid-base numbers, unless you have from the patient before, but we'll assume population normals. Remember, this is a female, so the PCO2 doesn't normally start at 40. It's probably around 37 or 38, and the bicarbonate is not 24, 25. It's usually 23, maybe a little lower. And remember, if it's a woman who's ovulating at mid-cycle, the PCO2 can drop even further. So they're never really they're in a pseudo steady state. It depends what, and obviously if someone's pregnant, then the PCO2 is going to be down in the third trimester for a chronic period of time. But assuming sort of normal numbers and we're not at the mid-cycle, roughly each number has fallen about the same amount. And so this would be most compatible with a compensated metabolic acidosis. So again, once you said that, you then have to divide it up by anion gap. So we look at the anion gap, and what's the anion gap in this patient?
11.
Yeah, so the anion gap is normal. Remember, when you talk, when this question comes up all the time, what's the normal anion gap? Remember, you have to know the hospital you're in and what the normal anion gap is for the machine that's measuring the anion gap, because in some hospitals, the chloride concentration is higher than others, and your anion gaps, the mean for the hospital is lower. They just because the chloride comes back higher. So you have to know what the mean is for your hospital, and 11 is roughly what you would see here normally. And also you need to know the albumin, because remember, if the albumin's dropped, that's going to lower your normal anion gap, because remember, albumin is negatively charged and is one of the anions contributing to the anion gap. So you must know all the time what your hospital's normal anion gap is and whether the patient's hypoalbuminemic before you let your brain even waste time thinking. Don't start thinking about what's going on. Because, for instance, if you have a patient with severe nephrotic syndrome or end-stage liver disease with a very low albumin, then this could be elevated. You know, if the anion gap should be 5 or 6, the patient might have a mild elevation of their anion gap here, even though if you just look at this simplistically, you'd say, yeah, the anion gap's normal and think it's a non-gap metabolic acidosis, but you might be wrong. So in this case, I don't have the albumin, but on an exam or when you're talking to your attending or a medical student or whoever, you'd say what your question should be immediately, what's the albumin, before you even begin to think. And until you get that, don't think further. So the albumin here was normal. And so this is a normal anion gap metabolic acidosis that's compensated. But obviously, we have a problem here, because when you look at the patient clinically with acute polydipsia and polyuria and a glucose of 600, what would you expect? What kind of metabolic acidosis would you expect to see?
DKA.
Well, that's a clinical diagnosis. That's not a diagnosis of the metabolic acidosis. I'm not talking about what caused it clinically. I'm saying what metabolic acidosis should you see here?
Anion gap.
Yeah, that's right. So you should see an anion gap metabolic acidosis due to DKA. That's correct. But why don't we? Why don't we see? We have a decrement in the bicarbonate. We have an elevated glucose. And yet the anion gap didn't go up. So what's the trick here? Why did the anion gap go up? What do you have to remember about anything in nephrology? We had an input, assuming it's ketoacidosis, we had beta hydroxybutyrate acetoacetate coming into the blood, right? So why don't we see an increase in the concentration of those anions as reflected by the anion gap going up?
Do you have to correct the sodium for the glucose at this point?
Say again, sorry, I didn't hear you.
Do you have to correct the sodium for the high glucose?
Well, that's a good question too, because if you have dysnatremia for whatever reason, remember the chloride drops too. It isn't just the sodium. We focus on the sodium, but if you just do the math, if you take, let's say, 140 minus 25 plus, let's say 100 and whatever, 105, whatever, you're calculating the anion gap. Now, if you decrease the sodium and the chloride by a certain percentage and redo the difference, you're going to find a lower anion gap. So you have to remember that as you decrease the sodium and chloride, whether it's because of a dilutional dysnatremia because of this, or whether it's any other kind of dysnatremia, the chloride and the sodium, unless you have a metabolic, or unless you have an acid-base disorder, change in the bicarbonate, just changing the sodium and chloride, whether it's vomiting, diarrhea, glucose, whatever it is going to, if they decrease, your anion gap decreases, just mathematically. And if your sodium and your chloride go up, if you have diabetes insipidus or hypernatremia, remember, you also have hyperchloremia. But anyway, when you do the math, the anion gap will go up. So dilution of those numbers decreases the anion gap by the same percentage. So if your sodium and your chloride decreased by 10%, your anion gap normality will decrease by 10%. But you would never be able to get the anion gap going from a high number down to totally normal with this mechanism, although it probably contributes. I mean, the sodium was diluted by how much? What's 140 to 130? It's pretty trivial. That's not going to change the anion gap by a lot, but it's a good point you bring up. So what's the major point here? And again, think of nephrology. You're always dealing with inputs and outputs of everything. The blood concentration of everything you see is a reflection of input and output from your body. So we know with some certitude that we have beta hydroxybutyrate and acetoacetate coming into the box. We know that indirectly because we had a proton coming in. We know that indirectly because the bicarbonate fell. So the fact that the bicarbonate fell in this clinical scenario tells us that a proton must have come into the system, and that proton doesn't come in alone, or you'll be sparking, right? You have to have electron neutrality, and it comes in with an anion. And the anions in this particular situation are not chloride, they're not bicarbonate, they're beta hydroxybutyrate and acetoacetate. So why don't we have an elevated anion gap? Anyone want to take a stab at it? Use logic rather than memorization. Just, think of what might be happening. I mean, one possibility some people say is, well, aren't those organic anions converted into bicarbonate? Maybe that's why. But if that was the case, the bicarbonate would not be 14. You still have a metabolic acidosis, but we don't see any evidence of the organic anions in the blood. So it's sort of like, where's Waldo? You have to figure out where they went.
I think, hey, Dr. Kurtz, this is Sean. I think the reason is she is actively urinating her ketones out.
Yes, that's very good. That's the answer. So, and you can predict that because there's no pre-renal failure here. The BUN and creatinine are normal, and so this patient's not volume depleted, as you might typically see in someone who's got an osmotic diuresis. Maybe she's drinking sufficiently. Maybe an IV was started and that wasn't written down here. But the bottom line is this woman has a normal GFR. And with a normal GFR, she's going to be filtering all those ketones normally. And remember, with beta hydroxybutyrate and acetoacetate, the proximal tubule can't absorb all of them normally. So it really depends on what your GFR is. And people with ketoacidosis who have a normal GFR and who aren't volume depleted can excrete a certain amount of the ketones that came into the bloodstream, or all of them. Now, there could be ongoing production of the proton and the organic anions, but the kidney is able to keep up with it. So the fact that you see this doesn't mean there's not ongoing ketoacidosis. And always a problem because people all the time as residents or medical students gauge the severity of the ketoacidosis in part by the anion gap, and that's just not true. It's only true if you have ESRD and you can't get rid of the ketones. Then the blood level that you achieve is totally dependent on the input. But in the presence of a kidney that's functioning, especially one with a normal GFR, you're going to be able to dump all the ketones. And so it looks like a non-gap metabolic acidosis. The bicarb falls and the chloride goes up by the same amount and the anion gap stays normal, as opposed to someone with a proton coming in with beta hydroxybutyrate and acetoacetate, where the proton comes in, the bicarbonate falls, but the chloride stays the same. To maintain electroneutrality, the ketones go up by the same amount as the bicarb fell. But the total ketones, which are negatively charged, plus bicarb, plus chloride, is what it was before, 120. Whereas opposed to this patient, where the bicarb fell from the protons, the ketones were dumped, and now the chloride goes up. So that's a very important point, because it doesn't mean this patient has anything less severe going on. And what you would do is measure the urine for ketones. And we see it in two situations, either someone who's spontaneously volume replete, who doesn't have pre-renal failure, or someone who therapeutically was given an IV and that returned the GFR to normal, and now the ketones get dumped in the urine. And also don't think, because if this was sort of a temporal change where the patient came in with an elevated anion gap, and then you gave saline and the anion gap goes to normal, don't think you've gotten rid of the ketoacidosis. All you may have done is dumped the ketones in the urine. You still have, and now you have the ongoing ability to get rid of them, despite the fact that you still have a production issue. So again, it brings back this issue. Remember, everything in nephrology is the simplest of all specialties in a certain sense, because everything we think about is input versus output. It's just, what are we talking about? Potassium, sodium, water, bicarbonate, carbon dioxide, everything we talk about, calcium. It's just we have different diseases or different names we attribute to problems on the input or output side, but conceptually, you're just dealing with changes in blood levels due to input-output problems. But remember that that's always the case. Don't ever focus on an output only, and don't focus on an input only, like people tend to do for ketoacidosis. There's always an output. Yeah, so very good. It's this patient was able to dump the ketones in the urine, and it looks like diarrhea. They can even, patient could be hypokalemic too, depending on how much potassium was lost in the urine from the osmotic diuresis. It can look somewhat like RTA. So remember that when we have ketoacidosis or lactic acidosis, we have a conceptual system here. You can look at the body like a box, and we have a proton coming into the box. And that's obviously not correct diagrammatically. It's coming from the ICF into the ECF. But be that as it may, think of the body as a box. You have a proton coming in with an anion that's not chloride or bicarbonate. And the proton will combine with bicarbonate in both the ECF and ICF. It's what we call the volume and distribution of protons. Remember that also, as an aside, the proton doesn't only go into your blood or the ECF. It's also decreasing bicarbonate in your cells. There's a known volume of distribution formula, which we won't go into today, that you need to be able to calculate how much bicarbonate to give. But remember, the protons aren't restricted to your blood vessels. They actually distribute throughout the body in a certain proportion of ECF to ICF. And so bicarbonate is lost from everywhere, even though clinically we only measure the decrement in the blood. So the proton is the causal agent responsible for the drop in bicarbonate, or what we say in English, there's a metabolic acidosis. But remember, the proton does not come in alone, or we would spark. You have to have an anion coming in. And in all these clinical conditions, it comes in with an organic anion, like lactate or beta hydroxybutyrate, whatever. The anion, and this is a very important point that people just either don't recognize or forget, the anion does not cause the metabolic acidosis. It has nothing to do with the drop in the bicarbonate. If I give you sodium ketone body or sodium acetoacid, or I give you sodium lactate, you're not going to change the bicarbonate because I didn't give you a proton. It's the proton that causes the metabolic acidosis. The anion is an additional substance which comes in and changes our anion gap. That's number one. And number two, the anion has carboxyl groups on it. So when the metabolic problem goes away, the organic anions are converted metabolically in the cells into bicarbonate. Now, we know that all the time, but people forget that in the context of a lactic acidosis and ketoacidosis. We give TPN, right, with acetate. The acetate is converted into bicarbonate. We give peritoneal dialysate solutions with lactate. The lactate is converted into bicarbonate. We give Scholl's solution. We give sodium or potassium citrate to treat metabolic acidosis or RTA. We use it all the time clinically, but we forget that the same thing happens when we don't give it. When the body puts these organic anions into the bloodstream during a lactic acidosis or ketoacidosis, those organic anions are also able to be converted into bicarbonate. And that's important because they contribute to the correction of the metabolic acidosis independent of the MD. So when you get rid of the cause of the ketoacidosis by giving insulin or volume, whatever you're doing, you're allowing the beta hydroxybutyrate and acetoacetate to be converted back into bicarbonate and correct the metabolic acidosis. But for that to occur, you have to have the you have to have the beta hydroxybutyrate and acetoacetate in the blood to begin with. So if you don't have them, like in this patient where the patient dumped them all in the urine, this patient's going to have a harder time correcting the metabolic acidosis because they've lost these organic anions. And so the anion gap, when it's elevated, when you correct the situation paradoxically or counterintuitively, those patients actually correct the metabolic acidosis faster than this patient will be able to do. So yes, giving volume or having a nice normal GFR gives you a non-gap acidosis pattern and allows the ketone bodies to be excreted in the urine. But when that occurs now, you've lost the ability to generate new bicarbonate from those substances. So sort of plus minus situation. And you have to be aware of that medically when you tell the medical student, yeah, we gave volume and the reason the anion gap got better is not because we stopped the ketoacidosis. We better check the urine for ketone bodies, and we can see the bicarbonate in the blood is still low. So we have an additional issue that now we've lost this substance that can correct things, and we're going to have to potentially, maybe depending on the decrement of bicarbonate, give bicarbonate ourselves. That has to be the conversation with the resident or the medical student. Does anybody have questions about that? Okay. Okay, here's another patient who was glue sniffing. Does anyone want to take a stab at what again, not the cause, but the clinical cause? What is the acid-base disorder first? And again, nothing fancy here. It gets very repetitive after a while. Anyone want to take a stab? Just go through your thinking out loud. Again, we're not talking about why we have these numbers. We'll get into that. But what does the pattern show? That's what you need for the exam. So what's the first thing you look at?
The total CO2 is low.
Good. So
it could be similarly metabolic acidosis or chronic or acute respiratory alkalosis.
good.
And then
That's it. That's it.
Yeah.
Exactly right. We tend to say the acute first just because acute occurs first. So it's not wrong what you said, but typically you would say acute or chronic, since the acute must occur before the chronic. But that's just a minor detail. But yes, you are correct. So which of the three is it? We look at the PCO2.
the PCO2 is lower than expected if you were to consider a acute or chronic respiratory alkalosis. So you could say that this is a metabolic acidosis.
Right.
Then,
So if it was acute respiratory alkalosis, for every 10 fall in the PCO2, which is the initiating event, right? I scared you and you started hyperventilating, you dropped your PCO2 from 40, let's say, to 28. The bicarbonate would be expected to, that's about 10 or 11. The bicarbonate should fall 1 to 2. How can it fall 10? So that cannot be acute respiratory alkalosis. And for chronic respiratory alkalosis, the bicarbonate falls half of what the PCO2 fell. Well, it didn't. It didn't fall by 5, or it would be 20. So the only numbers that these are compatible with is where you have roughly the same fall in both. And that's sort of, you can, the metabolic acidosis, you can remember very easily. You expect the same fall in both, equal. Chronic respiratory alkalosis, the fall in bicarbonate's half of what the PCO2 is. So those you can distinguish right away. It's not 2 to 1, so it can't be chronic respiratory alkalosis. It looks like it's 1 to 1, and it definitely can't be acute respiratory alkalosis because the bicarbonate should be falling 1 to 2 for every 10, and here it's falling, much more than that. So it is compatible with a compensated metabolic acidosis. Okay, carry on.
Can I just ask, when you're saying it is a I'm like in my head calculating Winter's formula.
Yeah,
Is
don't do
not
that
the
anymore.
way to do it? Okay.
Don't do that anymore. Yeah, rid your brain of the Winter's formula. That's medical student resident stuff.
Okay. And then
for some reason, that Winter's paper just took over the planet. Don't know why. It's just like something people love. We don't use that formula. You need the intercept and the slope.
Okay.
One reason for not doing it is if you want to be exact, there's an intercept and a slope formula for every acid-base disorder. And we don't have a name for it. Perhaps we don't have a name. We don't have Schwartz's name, who came up with most of the regression lines for each of these. So because of that, it's sort of unfair to focus, and that's an emotional statement, and I know it doesn't make any sense. But we're not doing it for all the others. So when you use the Winter's formula, it sort of is elevating that above the others, which I don't like, because all of them have an intercept and a slope with different numbers that you're not using. And secondly, and more importantly, you don't need it. All you have to remember is that in metabolic acidosis, the PCO2 and bicarb fall approximately the same amount. That's all you have to remember. It's so easy. If they're not the same amount, roughly, it can't be a compensated metabolic acidosis, plain and simple. The change in the PCO2 and the change in the bicarbonate are roughly equal. Very close, like 1.1 to or 1.2 to 1. We're talking trivia. Whereas in chronic respiratory alkalosis, the change of the bicarb is half of the PCO2, or 2 to 1. And in acute respiratory alkalosis, it's like 10 to 1 or 10 to 2. They're very different. But the metabolic acidosis, you never, ever again have to use the Winter's formula unless your brain is so used to thinking about it. And unfortunately, people come to their fellowship knowing that particular equation, but they ignore all the other equations for some reason. It's just the way people are taught in medical school and their residency. They all have co-equal formulas. And the easiest way to remember is just the slopes. You don't need the intercepts for any of them. Empirically, you don't. And so to know whether someone has a compensated metabolic acidosis, just look and see if the PCO2 fell by roughly what the bicarb fell. You don't have to be so exact anyway, because you don't know the original numbers. You don't know that the PCO2 fell by 12 and the bicarb fell by 11, because you don't know what the patient's original numbers were. That's an assumption too. You don't know the PCO2 was 40 chronically. You're assuming that. You don't know the bicarb was 25. Now, I'm not saying you know otherwise, but you're making that assumption. That's true for the Winter's formula also. How can you use the Winter's formula if you don't know, what the original numbers are?
Perfect. Okay.
That's sort of the long-winded answer, but I think one thing you can do for those on the call is get rid of the use of the Winter's formula. It's not that it's wrong, it's just not needed. You have enough to think about. Just see that you look at the numbers and your brain goes, did they fall by the same amount? Yes or no? If they did, you're compensated metabolic acidosis. And it's roughly 1 to 1 here. Definitely not 2 to 1. So it can't be chronic respiratory alkalosis, and it can't be acute. Bicar fell way too much for what the PCO2 fell. So that's sort of a long-winded answer. So again, this is a compensated metabolic acidosis. So carry on, you're doing well. So what's the next subdivision? Once you say
So
it's
then you want to calculate the anion gap,
very good.
and
So
it's
look at the
8. Yeah, so it's 8. So it's a non-anion gap metabolic acidosis.
good. And some people will say hyperchloremic. That's fine. There's synonymous.
Mhm.
So it's a non-anion gap metabolic acidosis. That has a differential diagnosis, which we won't get in. We'll talk about that separately as a separate topic. But in general, and not in this case, unfortunately, but in general, it falls into renal issues or GI issues. And there's just have to memorize those. These are now what we call clinical causes of the acid-base pattern, which you diagnose correctly. So first the acid-base pattern or acid-base diagnosis, and then your brain goes to the next step. What are the potential clinical causes of that? And separate those ideas. Don't mix those two things. The first thing is, what's the acid-base diagnosis, independent of what the clinical cause is. Okay, so as I say, normally it would be GI or renal. In this case, it has something to do with the glue sniffing. We look at the urine numbers, and the urine pH it seems elevated for what it should be. I mean, intuitively, you'd think it would be lower if you have a metabolic acidosis. That's always a question, is the urine pH what it should be? And that is a real hard question to answer because, first of all, no one's ever done in-depth exact studies of what urine pHs are under different levels of plasma bicarbonate for different causes. And secondly, it can vary with what diet you're on. It can vary with what the potassium is. Potassium affects the ammonia production by the kidney. And if there's more ammonia production, it binds protons in the urine. That's why in diarrhea, you can have an elevated urine pH. You don't have distal RTA. People with diarrhea who are hypokalemic have an elevated urine pH because there's a lot more NH3 being added to the urine, and it binds protons. And the free proton concentration, which is the pH, decreases. So the urine pH goes up. It has nothing to do with the inability to secrete protons. It's just now you've got this other substance, NH3, which just sops up all the free protons and the pH goes up. But that's true of anyone with hypokalemia. When you have increased ammonia production by the kidney and entry of that NH3 into the urine. The urine anion gap's positive here. Normally it's negative. We would normally interpret that as little ammonia in the urine. However, when we look at the urine osmolar gap, which is a better reflection of the urine ammonia, it's 300. Remember, you divide that by 2 to get the ammonia concentration. Simplistically, it would be around 150. So that's pretty elevated urine ammonia concentration. And yet the anion gap's positive. So that's confusing. Remember, nowadays at UCLA, I've been able to get the clinical lab in the last year to allow you to measure the urine ammonia. So you shouldn't be doing at UCLA urine anion gaps. Urine osmolar gaps, people don't really know as much, even though it was clearly shown it's better as an assessor of the urine ammonia than urine anion gap. But neither should be used to. You should be sending off the urine for ammonia here and assessing what it actually is. Having to do this is really historic, at least with our clinical labs. Although in 99% of the hospitals in the US, they're still stuck with doing sort of this way. Here, we don't need to do it anymore. And you should educate your attendings because most of them don't know about it. Okay, so how do we explain here? If we take the urine osmolar gap at 300, divide by 2, we get 150. At face value, that means there's more ammonia in the urine even than normal, and yet our urine anion gap is positive. How can that be? Anyone want to take a stab at it? And then also we'll have to talk about the urine pH in a minute. What's going on in glue sniffing? Particularly toluene intoxication. It's glue sniffing that has toluene in it. It's been known since the 1970s. Well, does anyone know what toluene is metabolized into? Okay, it's metabolized into something called hippuric acid. There's also some benzoic acid. But the bottom line is it's another organic acidosis, and the proton comes in with hippurate. Okay, well, you might expect then, just like in a lactic acidosis or ketoacidosis, that the urine ammonia would be able to go up, right? I mean, remember I showed a few talks ago that when you have a metabolic, extrarenal metabolic acidosis, the kidney compensates by generating more new bicarbonate than it did previously, and that new bicarbonate is created in a reaction that also generates more ammonia. So when the kidney is generating more new bicarbonate, you also find more ammonia in the urine as part of that those reactions. So it looks like the kidney is responding. Normally, the kidney is trying to generate more new bicarbonate here to compensate for the proton load. Obviously, it didn't do it exactly what it should, or we never would have developed the metabolic acidosis in the first place, right? And that brings up another point, thinking of input-output again. In a lactic acidosis or ketoacidosis, the kidney responds by generating more new bicarbonate before. Remember, it normally makes about 70 millimoles a day to match your daily hepatic proton load. But in an extrarenal metabolic acidosis, for whatever reason, you started a hydrochloric acid drip, patient has a lactic acidosis, whatever the reason, the kidney revs up its new bicarbonate generation. If it's able to match it completely, you won't ever see a drop in the bicarbonate. So you can theoretically have a lactic acidosis or ketoacidosis with a normal bicarbonate and no metabolic acidosis, just because the kidney is compensating by making sufficient new bicarbonate to match that elevated proton load. It's no different than you giving bicarbonate. The kidney's doing it on its own. It's only when the kidney has revved up maximally to its maximum capability that you then start seeing the bicarbonate fall if the load exceeds that. So remember, again, it's sort of another idea of an input-output issue that you can apply to any metabolic acidosis. Okay, so we know that there must have been new bicarbonate generation because the ammonia is high in the urine, and yet the anion gap's positive. We should be seeing a very negative urine anion gap, right? Normally we get a positive anion gap when there's little ammonia in the urine. Remember, the anion gap in the urine is the unmeasured anions minus the unmeasured cations. So if the unmeasured cations goes up, which is in this case the ammonium, NH4+, then the difference should be more negative. The only time we see it positive, or conceptually see it positive, is when the unmeasured cations, which is the ammonium, drops to very low levels. Then you end up with, a number that's 0 or positive. So does anyone want to think of how these two things can go together? A high amount of ammonium, NH4+ in the urine, which is the unmeasured cations, but the difference of the unmeasured anions minus the unmeasured cations is positive instead of extremely negative. Anyone want to take a stab at it? Because this they could show you on an exam. Well, the answer is there's hippurate in the urine, and hippurate's an unmeasured anion. So if the unmeasured anions goes up to a greater extent than the urine ammonium went up, right? Now you've got unmeasured anions minus unmeasured cations. Well, to turn that into chemical substances, we're talking about hippurate minus NH4+. If the hippurate concentration in the urine went up to a greater extent than the NH4+ went up, your difference is going to be positive, or 0 or positive, but it won't be as negative. If the hippurate didn't change, if the unmeasured anions stayed the same as before, then yes, you get a very negative number. So remember, the urine anion gap is a reflection not just of the unmeasured cations, but of the unmeasured anions. And in the case of toluene sniffing, you have a ton of hippurate in the urine. And in fact, the anion gap may not, again, it's the same story as the ketoacidosis, where you're able to excrete the hippurate. If you get, pre-renal failure and a low GFR for whatever reason, yeah, your anion gap will go up because of hippurate going up in your blood. But if you're able to excrete the hippurate, then you're going to have a normal anion gap. It'll look like a non-gap metabolic acidosis, even though the cause was an anion gap type metabolic acidosis. The blood pattern is hyperchloremic or normal because you got rid of the hippurate. But in the urine, if you're looking at urine anion gaps, you're going to end up with a potentially positive urine anion gap, not because the unmeasured cations went down, but because the unmeasured anions went up. It's the same thing. I didn't show it with a ketoacidosis, but you'd see the same Same thing in someone with ketoacidosis who's excreting the ketones in the urine. If you measured the urine anion gap, you're going to get a positive number, even if there's a ton of ammonia in the urine. The same sort of idea. Okay, I think we'll stop there for today. Again, this just brings up a number of clinical scenarios where the organic anions are excreted in the urine, and then conceptually how that reflects your thinking about what's going on in the blood and how that might perturb some of the measurements you might make in the urine, in particular, whether the patient's generating a new bicarbonate as expected, as reflected by the urine ammonia excretion rate. Remember, clinicians and residents and maybe yourself will think of the urine ammonium as getting rid of protons in the urine. That's not the way you should think about it. The urine ammonia in the urine is a reflection of the bicarbonate generation capability of the kidney, because the ammonia is generated in that same reaction. And the more ammonia there is in the urine, the more new bicarbonate the kidney generated. And the context is usually in responding to a metabolic acidosis. The kidney compensates by generating more new bicarbonate in an attempt to keep the bicarbonate in the blood from falling. But coupled with that reaction is additional ammonia production, which in part goes to the urine and in part, unfortunately, goes back to the blood. As we talked about, it consumes some of that bicarbonate in the urea cycle. Now, the last point I want to make is that in any cause of hypokalemia, there's two reasons for those reactions being stimulated in the proximal tubule. In a hypokalemic patient, you also generate more new bicarbonate and more ammonia, and it's not clear why that is. It's really not clear why. People have different hypotheses. Maybe these are mitochondrial reactions. Maybe the mitochondrial pH is changing. Not clear why. But in anyone with diarrhea or vomiting or any cause of hypokalemia, if you measure the urine ammonium or the urine anion gap divided by 2, or worst of all, the urine anion gap to calculate it, but let's just say you measure the urine ammonium, you're going to find it's higher than normal that you would expect on this same diet. And this could be a patient who's vomiting with metabolic alkalosis and their urine ammonium's high because they're hypokalemic. So it's a stimulus of the same reaction. And the important point, though, is in any patient who has a high ammonia production and excretion rate, that NH3 gets protonated by binding to protons that are in the lumen of the collecting duct. It comes into the collecting duct as NH3, predominantly on the Rh proteins. You remember the Rh blood antigens? Well, those Rh proteins are also in the collecting duct of the kidney, and those are NH3 transporters. I don't know if you know, but that's what the Rh protein does when you're assessing whether the mother is Rh positive or not. Those Rh proteins in a red cell, and importantly for what we're talking about today in the collecting duct, are ammonia transporters. And so those are the main mechanisms for getting NH3 from the interstitium into the final collecting duct. And we'll talk about NH3 transport and production in the nephron another time. It's a complicated subject, but sort of the end of all the production and intra-nephron transfer is that the NH3 from the interstitium that came out of the thick ascending limb gets into the collecting duct, but it gets through the cell wall, not through the lipid bilayer, but through these Rh proteins. Once it gets into the lumen of the collecting duct, it gets protonated because the pK of the NH3, NH4 reaction is about 9.2. So at a luminal pH in the 7s or 6s, that NH3 is going to get protonated. Predominantly, it'll be protonated. Very little will be free NH3. But when the protons bind to the NH3, they raise the urine pH, unless the cell secretes more protons in addition. But in general, when you add more NH3 as the experiment, the thought experiment, to a solution or to the collecting duct solution, the pH goes up. And so it looks like RTA, the patient's hypokalemic, the urine pH is high, but when you measure the ammonia in the urine, it's high, not like distal RTA. And so you can be fooled on the ward in a patient with diarrhea who's hypokalemic. Common question is this distal RTA? They have a non-gap metabolic acidosis, the urine pH is high, they're hypokalemic. The answer is, let's give potassium and see what happens. So as you give potassium and raise the potassium to normal, you shut off the ammonia generation, and then the urine, you have less NH3 in the lumen of the tubule, less substance for the protons to bind to, and the urine pH now drops. So you get this therapeutic drop in the urine pH in a hypokalemic patient just by giving potassium. It's an important teaching point because it's not uncommon to be asked, is this distal RTA, when in fact it's diarrhea. And the reason the urine pH is high is not because of a proton secretory problem, but because you have this substance NH3, which binds protons avidly. And now there's less that are free in solution, which is what we're measuring when we're measuring the urine pH. We're not measuring the total proton content, bound and unbound. We're only measuring the free when we assess the pH. Okay, so I think I'll stop there today. Does anyone have any questions?